I'm going to introduce our speaker today. Stephen Johnson is an associate professor in the Department of Psychiatry at the University of Kentucky with a joint appointment in the College of Social Work. He did his undergraduate work at Tennessee Tech University, where he earned a BS in technical communications. He earned his master's and doctorate in social work from the University of Kentucky. Dr. Johnson is the director of psychotherapy and psychological services in the Department of Psychiatry. Besides seeing patients for mental health and substance abuse issues, he teaches residents and graduate students in mental health and psychotherapy techniques. He is also the coordinator of mental health services for the Bluegrass Care Clinic at the University of Kentucky. So everyone, welcome Dr. Johnson.
Thanks, John. It's great to be with you and everyone else today. I appreciate you taking the time to log on and talk about something I feel like is important, particularly in the work that I do, but also in the work that you do as well. We're going to, I want this to be as beneficial for you as possible. So if you do have a question that you feel like is important for us to answer today, or you feel like particularly germane to our discussion at the moment, I'm happy for you to interrupt me, just unmute and do that, or you can certainly put a question in the chat box, and I think Chris and John will monitor that for me as well. But the more interactive we can be, the better. So before we get going here, well, let's get through these first couple of slides. John, go ahead. So I have no financial disclosures to report to you that would cause any kind of conflict of interest in me giving this talk today. And we're going to look at the unique healthcare needs and treatment considerations for the LGBTQ plus population. And particularly, we're going to frame it in a theoretical understanding through minority stress and how this affects recovery and is crucial for the treatment of opiate use disorder and substance use disorder in general in this population. So hopefully today I will challenge you to think about the unique challenges faced by individuals with an opiate use disorder who also identify as LGBTQ+. Hopefully today we'll recognize and understand the impact of minority stress on opiate use disorder and how it impacts recovery, and identify cognitive and behavioral ways to address minority stress in the context of opiate use disorder. So before we get to this question, we'll go ahead. I have a little video that we're going to watch to sort of set the stage for today's talk.
To treat me, you have to know who I am. I identify as the Latina lesbian mother.
To treat me, you have to know who I am. I identify as a transgender man.
To treat me, you have to know who I am. I identify as a gay man. I was diagnosed with anal cancer, and when I'm dealing with something medical, it's extremely important that they know who I am. Every doctor I've been to, and there were 7, all of the nurses, all of the assistants, everyone treated me with respect.
It is as important to know somebody's sexual orientation, and even more than that, what their sexual scenario is, as it is to know if they're getting a good night's sleep, or if they have a good appetite, or if their bowel movements are normal. It's all part of basic bodily functions that are required for a maximum quality of life.
It's important to have an open and honest relationship with your patient. And so if you do not know what their sexual orientation is or how they identify, that patient is not going to feel safe telling you everything that they need to tell you for their proper medical care.
Knowing a patient's gender identity and sexual orientation helps a practitioner to care appropriately for that patient We see a lot of patients come in who may not be comfortable disclosing that information, and routine testing or screening may be missed for that patient.
When I was about 15 years old, I remember going into the doctor's office, and my doctor was very warm and very welcoming. She was asking me all the questions that she's supposed to ask to an adolescent, and I remember telling her when she asked about my sexual activity if if I use condoms or anything like that, and I said, no, I'm gay. And I just remember her face changed very much, and her warm tone of voice turned very harsh, and it seemed as though she was rushing me out as quickly as possible.
As a lesbian, unfortunately, when I've been involved with the healthcare system, it's usually hasn't been very welcoming. It's usually assumed that I'm heterosexual, and so the questions go along that line, asking me about the need for birth control. And then I fill out forms that ask me if I'm married, single, divorced, or widowed. And none of those boxes apply to me.
I think it's very important to know that what people write on forms does not represent necessarily their reality. And it does not take the place of a provider opening the door to ask questions.
And you need to ask those questions in an open and thoughtful and caring way.
Many times the patient or client want to talk about their sexual health, but fear that they would be discriminated against or stigmatized.
There are a lot of ways that a provider could ask me questions that would make it more likely for me to disclose the fact that I'm gay than not. So I'd rather them ask me if I am in a significant relationship, if I have a partner. And then I'd like them, when they talk about other issues, to not make an assumption that because I'm gay I don't want to talk about having kids, or that I don't want to talk about relationship issues.
My partner and I and our children were on a family vacation, and my older daughter became sick. She got stomach pains, and we had to go to the local emergency room. And we get to the hospital, and they asked who was my daughter's parents, and I said, well, she has two moms. And they were like, well, she can't have two moms, only one of you can go in. My daughter was traumatized by that. We were traumatized by that.
It's not about sensitivity, it's about respect, it's about humanitarian response to a human being in general.
My partner was hospitalized recently, very severe aortic aneurysm. When he was being moved from intensive care to a hospital bed, the nurse in charge would not let me accompany him. I asked if I would have been allowed to accompany him if I were part of his family, and she looked the other way.
What needs to happen when a patient is admitted to a hospital is that the care providers think about the fact that the patient might have different sexual orientation or different gender identity than the care provider.
Throughout my pregnancy, I was very much genderqueer, and I did tell them about my pronouns, which ones I preferred, that I preferred gender neutral or masculine pronouns. But the people who were dealing with me throughout my pregnancy, primarily my midwife and the nurses associated with them, were not responsive to my identity and didn't actually respect it. Certainly I felt that my healthcare has been impacted. I feel less genuinely listened to, and I feel like there's a huge discrepancy between the care I get versus other people who have gone to the same provider and report a very different experience.
You need to empathize with the patient you're talking to, give them an understanding that you care to understand who they are. That's all you need to do. You don't have to use the right words. Just be open to being educated on what right words to use and care.
I just transitioned about 4 years ago to start living as a man. When I was diagnosed with breast cancer, I found that my breast surgeon was unable to call me, even to give me my biopsy results. He did tell me very frankly and overtly that he had problems with my transgender status. And upon meeting me and learning of my transgender status, he decided that his first impulse was to refer me to psychiatry.
I used to work at a health center that did a lot of care for transgender patients, and there was a lot of discrimination towards those patients. There was discomfort in talking to them. I myself had some discomfort because I didn't have much training in how to work with transgender patients.
The other day, a patient came into the office and his insurance cards identified him as Adam, although he signed the register as Emily. After being called multiple times by his birth name, he left the office.
I do think the LGBT community has special needs. I think the LGBT community has a specific special need, which is to be treated the way non-LGBT people have been treated forever, which is to be asked about their sexuality, to be asked about their quality of life, what their home situation is, what their work situation is, what their friend situation is, without the person asking the questions being afraid of what the answers might be.
Recognizing the differences of human beings and being able to address the issues and not using one ruler to measure someone else's existence or purpose in life.
My greatest hope for LGBT patients in the healthcare system is that when they go for treatment, whoever they're going to see accepts them for who they are.
Then having the people that we choose to be our families be accepted, to have them be a part of the healing process.
And the healthcare system can take care of us just like anybody else so that we can keep ourselves well and get the information that we need.
To treat me, you have to know who I am. I identify as a lesbian.
To treat me, you have to know who I am. I identify as a genderqueer, biracial, Latino parent.
To treat me, you have to know who I am, and I identify as a lesbian.
Our lives depend on your capacity to care.
So thanks, John. That was great. So let's do some audience participation now. It's as people who work with folks with opioid use disorders and substance use disorders. Why do people use drugs? I'm sure you have some opinions about it.
Well, from experience, the person may not feel comfortable in their own skin, to feel different, to feel better about themselves, even though it can cause harm. It's that's been my experience.
Yeah, to get a head change, right?
Yeah.
And then I'm just going to read a few answers from the chat. Self-medicate, untreated trauma, to mask pain, escapism, isolation from family and community. It's what they've always known in their home life, to dull pain, gain confidence.
Yeah. Anybody else got any others? Those are great. So with any population, I think understanding the context of specific challenges and how things occur is going to be important. So certainly opioid use disorder there's lots of commonalities that it doesn't really depend on what community you're in, right? So we know that whether you're, you know, gay or straight or black or white or American or European or, you know, high on the socioeconomic ladder or lower on the socioeconomic ladder, there are all kinds of stressors that go on that we think contribute to why people seek to escape their reality or get a head change or want to deal with physical or emotional pain, right? So everything that we talk about today, I want you to keep in mind that we're not trying to narrowly focus and find the answers for this, but there are, you know, certain commonalities that we see with all people who are addicted to opiates, but we also see some common factors and common things in this particular population. And so today, while you keep in mind that this isn't the answer for all people, right? Everyone's unique. And so I'm not saying that every LGBTQ person that you come in contact with are going to have these particular issues. What we do know and what we try to do is we try to look at what are some commonalities that we need to be aware of by not stereotyping people, but looking at what we know to be true from research about what people have reported as being issues in their lives. So, so understanding LGBTQ substance use requires understanding the dynamics of the community as well as those of the individual, right? So there's going to be commonalities and there's going to be some individual differences, but understanding those dynamics is important. So anyone working with LGBT substance users, it requires us to be value clear, right? So that not imposing our value system on individuals, to suspend our judgment of why a person may have gotten addicted or why they continue to abuse substances. And then also to be very clear of our own biases and try to name and resist those stigmas that we have for people who are clearly in crisis or in a bad situation. Okay. So multiple studies across time have indicated problematic use of opioids and other drugs in the LGBTQ plus persons. And most studies say that it's 3 times that of what we think of as typical heterosexual population. So that in and of itself is, if you're going to work in this area and you're going to treat people for substance use and opioid use problems, then you're going to run across individuals who identify as LGBTQ. That's what you're signing on for. And you probably know that. I know in a lot of ways I'm preaching to the choir about this, but so you see some more statistics there of 20 to 30% of LGBTQ people who identify with that report problematic use versus 10% of the what we think of as the general population. Also, particularly of note, and we'll talk about maybe a little bit later in this discussion, people who identify as gay, men who identify as gay, or men who have sex with men. There's a strong prevalence of alcohol use, marijuana, psychedelics, hallucinogens, stimulants, sedatives, all kinds of things that go along for different reasons with that particular culture. Strong correlation between substance misuse and sexual behavior. And we can talk about that some more as we go ahead. Okay. So this slide is actually fairly old, even though it says recent, but 26% of misuse drugs or alcohol specifically to cope with discrimination they faced due to their gender identity or expression. These are reports from studies with transgender individuals. 41 of the respondents reported attempting suicide compared to 1.6% of the general public. So what we know is that these individuals are a huge risk for overdose, huge risk for attempted suicide compared to the general population. So I won't talk about the legislation that we have currently going on in Kentucky that we can't do gender affirming care, even though we know that these individuals are 4 times as likely to attempt suicide. So 4 times the national average of HIV infection compared to the general population, and rates for trans people who identify as transgender women, at 3.76 up to 15% if they're are sex workers. Okay. So according to a 2015 national survey on drug use and health, LGBT men and women across all age brackets were significantly more likely to have misused prescription pain relievers in the last year compared to heterosexual adults, and had almost 3 times greater risk of opioid use disorder compared to heterosexual adults. So this is significant. Again, we're looking at 3 times national averages for folks. And again, if you look back over at your chat box, you think about, okay, people who identify as LGBTQ plus, the things that you listed there for why people use drugs tend to be higher in those individuals, and we'll talk about why that is and what's going on. But you pretty much identified why this is a particular issue for this particular population. Okay, next. So it can be confusing at times to understand the changing terminology in the LGBTQ plus community. It's hard for me, and I work pretty extensively with this population. So when someone brings a new term to me that I haven't heard before, that they identify as, gender fluid, or if they say something about a throuple or something that I've maybe not heard before, then I was like, I always looked at it as a great opportunity to increase my vocabulary, and you should too. I think the biggest mistake you can make is assuming you know what someone's talking about, and maybe you don't, and maybe a word that has changed meaning through the years. We used to use the word transsexual, which you may still hear. I guess somebody could identify as that. We don't use that word very much, or I don't hear people using that word much anymore. So make sure you or the word transgendered. People will say that individual is transgendered. That's not really an acceptable term, because someone's not past tense. Their gender is not a past tense kind of thing. I don't know where that one came from. But so when in doubt, ask someone if they say something that you don't know the term, because that does 2 things. It shows them that you're open to learning and want to know what they're talking about. You want to understand their particular sense of self, or how they're identifying, or what their behaviors or what they're doing, that you have that interest, and it's important for you to understand it. And then it also gives a level of acceptance to say, I want to identify you and use terms that are appropriate to your situation and how you use them. So, and we all know what happens when you assume that you know something and maybe you don't. So if you've not seen the gingerbread person before, you can Google this and look it up. I like this as we talk about trying to understand gender and sexual orientation. But you can see the website there if you want to look it up. There's actually been several other iterations of the gingerbread person that include more things. But I like this one because it's sort of a simple, basic introduction to thinking about these cultural and social phenomenons in the way that we identify people. So let's just go through some of this. And, again, this is sort of just a basic introduction, but I think it's a good way for you to think about some of these terms and some of the things that we're going to be talking about today. So gender identity is how you think about yourself. So you'll see their identity is in the brain. So it's the chemistry that composes you and how you interpret what that means. So how do you see your identity? How do you think about that? Is how you identify, or it's your identity. And it's usually placed in what we think of as societal gender roles, right? So as a society, we have gender roles that we think typically for male and men. And we have gender roles that we think that are typical for females and women. And so this is how you fall on this continuum of what your identity is to you, how you identify as we think about typical gender roles. Okay, so this is something how you think about yourself, right? So I could ask each of you, and you should be able to put an X on this line somewhere of how you think about your gender identity. Okay, so gender expression. So that's a little bit different. So you'll see there the line goes all around our little genderbread person. But this is how you convey your gender to the world. This is how you express your gender. So it's how you dress. It may be whether or not you wear makeup. It's how you behave. It's your mannerisms. It's how you interact with people. And do you do that in what we think of as a more masculine way? Or do you do that in a more feminine way? Or you do that in the middle of this idea of an androgynous way, meaning it's neither really masculine or feminine. So how do you express yourself, and how do you express your gender to others? And it can change in different situations. So sometimes your gender, you may be working with a client or a patient that sometimes they may dress very androgynously. In other words, it's very, very, you can't tell what expression they're having. And then you might see them for the next visit and they may be presenting more feminine in that visit, or it may be a combination of those things. So again, how you choose to express yourself is your gender expression. All right, biological sex, and this is again where sometimes people get confused. How you were born biologically, by objectively measuring your sexual organs, your hormones, your chromosomes. So we say that people with XX chromosomes are female. In biology, we say people with XY chromosomes are male. And then what your genitalia is, we then determine what we call your sex. Now, this has nothing to do with your gender expression. It has nothing to do with your gender identity. For a lot of people, those are synonymous, right? So in other words, you're born biologically female, and you, in your mind, you identify as a woman, and you express yourself in a basically feminine manner. Great. That's the case for a lot of folks. Some people, that's not the case. You may be born biologically male, but your gender expression, your gender identity in your mind is that of a woman, and you feel like you are a female, and you choose to then maybe dress more androgynously, or maybe more in a feminine manner, so that if we were marking X's on this, you would be over on the male side, but maybe on the woman side as far as gender identity. So those are all three components or conceptions or constructions of what we think of as gender, right? This last line on here has nothing to do with whether you're a man or a woman. This is your attraction. So you'll see it's listed there on the heart. Could also be listed in the genital area, I think is appropriate too. But this is who you are sexually attracted to. So again, it has nothing to do with whether you're a man or a woman or how you identify. It's who turns you on, right? It's who and what do you find sexually attractive. And so some people, if you're attracted to the opposite gender, you would probably identify as heterosexual. If you're attracted to the same gender, you might identify probably as homosexual. Or if you are attracted to both, you might identify as bisexual. And again, it gets a little more complicated because, again, you may be attracted to someone's gender expression as well as who they identify gender-wise, but maybe not to their biological sex. Wait, what did he just say? Yeah. So what he just said was that you could be attracted to people for lots of different reasons, right? But the mistake I think that some people make is we think that our sexual orientation is somehow tied to our gender. And it's not tied to your own personal gender, it's tied to your preferences in other people. So that's the difference. So gender is about you. Sexual orientation is about what you find attractive in other people. So that's just, a very quick overview, hopefully that didn't confuse you more about what we think of when we're talking about gender identity and gender expression and sexual orientation. Any questions about that? Okay, here's another little more detailed description from the Fenway Institute about sexual orientation. And it basically is just thinking about these three components again, because a lot of times people think of it's all just one thing, but I'll break it down for you a little bit here. So sexual orientation can be about your identity, whether you identify maybe as a gay person or a lesbian individual or a bisexual individual. So that can be part of how you identify yourself. Or it could be more about your behavior, who you choose to have sexual intimacy with, or who maybe you're sexually attracted to, or who you're romantically attracted to. And that could be whether you act on that behavior. We have some individuals that will say, I enjoy having, let's say, a man that has sex with other men on occasion, but they do not identify as gay, and they do not say that they are romantically attracted to other men, but they enjoy having sex with men on occasion. So it can also be the third part there is who you're attracted to, whether you act on it or not. So we have individuals who may identify as gay, but have never had any kind of same-sex interaction. So keeping all those things in mind too, as you talk about sexual orientation with people. And again, this can change. So if you're working with an individual who is in the coming out process, or maybe is in some kind of stages of change in their life, one visit they may identify one way, and then the next visit you see them, something has changed and they're identifying in a different way, which is totally fine. Next. So some of you have heard of Alfred Kinsey. He was from Indiana. He's this dude that came up with the idea that maybe everything is not binary. In other words, maybe there's something different sexually besides gay or straight or heterosexual or homosexual. So he proposed this sort of Likert scale of maybe there are degrees of sexuality, or maybe some people don't identify completely or purely as one or the other. So he came up with this scale and idea of different people at different times and different situations may see themselves differently as far as their sexual orientation. So we have sometimes folks that are maybe because of certain situations, like if they're in prison or something, they may have what we think of as a change in their sexual orientation, where they're having homosexual encounters, or I've talked to individuals too that identify as homosexual but have had an affair with someone of the opposite sex because they fell in love with their roommate or something. So this is also something that can change through people's lifetime. It can change during your lifetime. It can change during a patient or a client's lifetime as well, how they identify. But it's moving us from either one or the other being mutually exclusive. So that's important to keep in mind as well. Okay. So yeah, as I was saying, sometimes there's distance between sexual behavior and sexual identity. So people can have sex with a same-sex partner and not identify as being gay or even bisexual. So there was a study done in 2006 of over 4,000 men in New York City, where 99.4% of the men who identified as straight in the survey said they had sex with a man in the prior year. So it's not unusual for folks. I've interviewed folks that identify as bisexual that say they had a same-sex encounter maybe in high school or college, then didn't have any more same-sex encounters until they were 50 or 60 years old, which then they decided again it was time to maybe explore that side of themselves. So we know socially that depending on how socially acceptable it is, that some people may not identify as gay or bisexual because of a racial or ethnic concern as well. Okay. All right, so we're going to talk about, again, some unique issues for this particular LGBTQ plus population that are not typically apparent in the heterosexual cisgender population. So let's start with heteronormativity. So this idea is the idea that it's normal to be heterosexual. So the majority of the population identifies as heterosexual. So instead of thinking as homosexuality or bisexuality or being sexually fluid as being a normal variant in sexual orientation, from a heteronormativity view, this is what heterosexuality is normal and everything else is not normal. So this is where we get the idea of folks being homophobic, which is basically a fear of homosexuality. But that's really sort of a misnomer. So it's not so much a fear of homosexuals in general. It's more of that you're not normal because you're not heterosexual. So there's a bias and there's an assumption that there's a right way to be and there's a wrong way to be, rather than we have variance in people's sexual orientation. So if we live in a world where that heteronormativity is seen throughout, and we saw that in the video, right, particularly in healthcare, where people make assumptions that folks are heterosexual without asking about their sexuality or their gender. And so it's this idea that permeates society that this is the right way, or this is the normal way, or this is the majority way, without recognizing minorities. Okay. You may hear the term internalized homophobia, and you may deal with it with patients and clients. Internalized homophobia is this idea of non-acceptance of self for being gay, lesbian, bisexual, or transgender. So it's this what we think of as self-denial, self-hatred, self-loathing because of someone that feels that they are not what they should be. It can be taught to them, through society. It can be taught to them through parents. It can be taught to them through religion. But it's this idea of I'm not accepting of myself. I feel less than because of who I am. And this turns into, obviously, avenues for depression and for anxiety and for substance use. If you don't feel like you're who you're supposed to be, or if you don't feel like you're who God wants you to be, or if you don't feel like who your church wants you to be, if you don't feel like who your parents want you to be, or you don't feel like who your friends want you to be, this can create this negative self-feeling of I'm a bad person or I'm less than because of my desires and because of how I see myself as far as gender goes. Okay, next. I'm gonna come to those other topics. I have individual slides for those. That's why we're moving on. So I will say this is that in research, a lot of times you'll see the term gender and sexual minorities used, and so there is some debate about whether this is an appropriate term to use. I'm going to talk about sexual minority stress in just a bit, but I wanted to give this little caveat before we do it. It's sort of a research term to identify a population and to identify a group, but there are some people in the LGBTQ plus community that don't like being called a minority because they feel it's pejorative and that they're being identified in a negative way and singled out for their sexuality or their gender. But it's more of a way to identify, as we talked about at the beginning, specific problems to a specific community that are unique. So I will use that term minority, but it's not meant in any way to be thought of as this group is somehow less than the majority. So I just wanted to say a word about that before we keep going. Okay, next. So this is probably one of the more unique and impactful developmental milestones for someone who's LGBTQ plus that the general population doesn't go through. So this is a process of self-acceptance, usually first of all, right? So this idea of admitting to oneself, I'm gay, or admitting to oneself, I feel like I'm a man, even though I was born biologically female. So this is this coming to grips with and coming to understand what it means to be attracted, have a same-sex attraction, or to struggle with feeling like your gender and your how you're being raised and your physical self do not match up. So that's usually the first stage. If you look at most coming out processes for individuals, is this awareness, self-awareness, and then some kind of self-acceptance. Self-acceptance doesn't, if that is a process that a person's dealing with and it can be a struggle, we oftentimes see individuals turn to alcohol or substance use or opiates to deal with this internalized homophobia of knowing this is who I am, but it's not who I want to be, right? This is who I am, but it's not who I want to be. What do I do with all this pain? How do I come to grips with it within myself so that I'm okay with it? After the individual has success with that, and it doesn't mean it's complete and total success of total acceptance, because if you ask yourself about just who you are right now, do you accept everything about yourself and love everything about who you are as an individual, whether you're gay, straight, whatever? No, it's not something that, you know, you wake up one day and say, oh, I'm perfectly fine with being a big homosexual. It's not something that, you know, happens overnight. It's not something that is sometimes not a lifelong struggle for people. But anyway, it is the first step, and people, usually before they come out to other people, they have to have this sort of coming out process to themselves. Then the next step is usually coming out to people that they trust and will know, will hopefully accept who they are. So this is usually to friends or family, and then coming out to others, healthcare providers, treatment providers, co-workers, strangers, and living their life in the most authentic way that they can. So it can often be a lifelong process. There can be forward progression, and then there can be backward progression. There can be individuals that you will work with that identify as gay, and then the next time they say that you see them say, I've started going to church and I realize that's not who I am. And so I'm dating, you know, someone of the opposite sex now. And that might be who they are for a season or two. And then they may decide that, no, that's really not my authentic self. I need to continue with this coming out process. So it's not always just a straight line forward. There can be progression, and there can be moving in different directions at different times. So, but it's a very unique milestone for folks. And it's, when I say it's a lifelong process, again, we live in a heteronormative society. So people are going to assume folks are heterosexual until sometimes they come out with them. So anytime you meet a new individual, there may have to be a coming out to that individual as well. So you say, well, I'm gay. And again, for some folks, that becomes as easy as saying I'm from Kentucky, or, I'm into basketball or whatever, and I'm gay. For others, it's still a very difficult process, and there's can be a lot of guilt and shame and negativity associated as well. So let's do the next video here, John. I think it'd be a good place to put this in.
All right.
So this next video is about, it gets better, from the Trevor Project that came out probably 15 years ago.
I knew from my earliest memory that I was gay.
I was, kind of a loner growing up.
I was very awkward. Called every name in the book. They'd say fag or nerd, egghead.
Like this, like that. People walking by calling me a waste.
Yeah, the mainstream didn't want us.
And high school's kind of shitty. I mean, it's like...
just there being no allowance for someone to be different.
There were
You know, definitely nights those years where I would go to sleep and just be like, I don't want to deal with this. I don't want to wake up in the morning.
I just wanted to curl up in a dark corner somewhere and hope that it all went away.
I felt tired, really tired.
When I was around 8, I told my pediatrician that I wanted to be a girl. It made me feel even more determined to hide that part of myself away, because the message I was getting is, you know, that's disgusting.
You have all these feelings that you can't necessarily talk about with somebody.
You know, and you're looking for that acceptance, and you don't always get it.
As much as my parents loved me, there was always that possibility that the two people that mattered most in my life wouldn't accept me for who I am.
And I had this kind of story in my mind that everyone was going to lash out at me and they were going to be mad and they were going to say, oh, you're going to hell. And when I thought about that, I became very depressed, and I had actually contemplated suicide.
Why am I like this? I wish I wasn't.
I found a bottle of sleeping pills in my parents' medicine cabinet and took them. All of them. Just a few moments before I lost consciousness, I had a fleeting moment where I thought, if it does get better and I'm gone, then I've really screwed up.
Every day is worth waking up for. You never know what's going to happen.
Life changes so much.
When I finally did come out and start to transition, I realized I'd been hiding a huge part of myself.
And it just came out. I said, I'm gay.
It feels like a weight has been lifted off your shoulders. And that was just incredibly liberating.
I'm finally me.
No way would I not want to be who I am, because my uniqueness is my strength. It's what differentiates me from other people.
To finally be open and honest with who I am, what I want out of life, and to my surprise, it was probably one of the best things that I had ever done.
You feel every sense of freedom and every sense of this is what life is all about.
Summer days at the park where all your friends are there.
And going on a long run when no one else is on the street.
The thrill of discovering what your career is.
Or even just being here to see the sunset or the sunrise.
I have people I really enjoy talking with, being with, doing stuff.
Enjoying the riches of life. That's the stuff that people shouldn't miss out on.
Falling in love and having a partner of almost 14 years.
We both play the piano. He plays the viola.
And someone who every night you want to say, I love you and I hope you'll sleep well.
That feeling of connecting to someone so deeply.
And sometimes I still shake my head, think I'm dreaming, because it got so much better that I ever thought it would be possible.
Just there's no way that anyone can really, really explain that to you until you really feel it. But if you're not around, you won't.
Don't try to do everything yourself. Find people who can help you if you can.
As difficult as it might seem, open up with somebody and just tell them what you're feeling.
You have to be open to people who even look like they might be your friend. They're friends. You're not alone. You're not alone.
The bullies seem like the powerful people and the successful people, and the secret of the real world is they're at the peak of their power at 15 and 16. And there will come a time when the bullies are not successful and the people they bullied are. And you just have to out-survive them.
They don't know you. They don't know who you are or what you love or anything about you.
Know that there's nothing wrong and there's people out there just like you.
Please consider that time, just a little bit of time sometimes changes a whole outlook.
No matter who you are or where you live or what you have swirling around you, that space that you're in, that time, is this much in the course of a life.
And as we go through our lives, we're going to have friends, we're going to have family, but they're not always there. And in that toughest, darkest moment, if we can rely on ourselves, that's more than we will ever need to face the world.
I've probably watched that video about 30 times, and I always get teared up when those people start talking. But so yeah, I think, you know, what's interesting that I was thinking about as I was watching this again, you know, these people telling their coming out stories. They're telling about, you know, how they felt before they were able to come out, and then how it got better. You know, with the idea of, you know, trying to give hope to other people, right, who might be struggling. But you know, you could watch this video a second time, and instead of thinking of folks talking about their coming out story, you could ask them, what was it like when you finally stopped using drugs? What was it like when you finally stopped being addicted to opioids? What was it like? Because I think the answers would be the same. You know, I enjoy walks, I enjoy runs. The world's so much better. I have a partner now. I enjoy, you know, all the great things in life that I could have enjoyed before. So I definitely see a very strong parallel there for that, which was the first time that had hit me thinking about that. But anyway, so as far as coming out, very unique milestone. You can see the impact that it has on people. You can see the struggle that they have internally, what their life is like sometimes, and then how things are so much better. So we always want to, you know, be encouraging to folks to come out, but at the same time, it's their journey. So I would caution you, because sometimes there can be big price tags for coming out, right? Rejection of family, rejection of support. So people have to do it when the time is right for them, but you can certainly talk to them about it. You know, somebody identifies in your office or in your treatment center as gay, and you're trying to establish rapport with them, ask them what their coming out experience was like. Because it does two things. It shows them that you get how important it is, and it shows them that you're accepting of that process and understand how difficult it can be. So it's a great way to build therapeutic relationship and rapport with patients by talking to them about this really hard time. And they may not want to talk about it. That's fine too. But they may really want to talk about it. So by the way, the people in those videos, that was the Apple employees. Those are the people that make your iPhone and your laptops. Okay, next. All right, here we go. Sexual minority stress. So this is what I really want you to think about, and what we've been leading up to, is that by understanding all the unique challenges that LGBTQ plus folks have, there is one way that we can theoretically frame this, and this with this idea of minority stress. So minority stress came out first in looking at racial minority stress. So this is some sociologists and psychologists started studying this. And basically what we're talking about is, what is the stress that is particular to an individual based on their minority status? Let me say that again. What is the unique stress that accompanies that is ever present for an individual based upon their minority status or situation? So racially, what is the stress of being a Black person that Black individuals face on a day-to-day basis? Is it, you know, racial slurs? Is it whether I'm going to be attacked? Are people not going to give me the opportunities that they would give someone else? Am I going to get pulled over and assaulted by a police officer? The things that are stressful to an individual based upon their minority status. So it's the kind of stuff too that maybe not is happening in front all the time, but it's the stuff that's running in the background all the time. So when you walk out the front door every day, what kind of stressors am I going to face today based upon the color of my skin? So we move this now to looking at it from a sexual standpoint or sexual orientation standpoint. So we can call this sexual minority stress or gender minority stress. But what are the stressors that an individual feels because of their sexual orientation that's unique to them because of that? What are the stressors that an individual faces because of their gender? So let's start with sexual orientation. So if someone finds out I'm gay, am I going to get fired? Are they going to laugh at me? Are they going to tease me? Are they going to try to convert me to being straight because they think I'm going to hell if I'm gay? Are my parents going to kick me out of the house? Am I going to get physically assaulted? Am I going to, insert whatever there? Am I going to be in danger because of if I live my life authentically? Same thing with gender. Am I, if I have a gender expression that's not typical, am I going to get teased? Am I going to get bullied? Am I going to get assaulted? Are people going to think less of me? Am I going to lose my job? Am I going to lose my friends? Am I going to lose my family? So you can see all these things that are ever present for these individuals who are trying to live authentically who they are. So this stress on top of regular stress, on top of finances, on top of weather events, on top of a global pandemic of coronavirus, COVID-19, all those things that we all feel stress-wise, they're there. But in addition to it are these unique stressors for being a particular minority that these people face. And so there are some in the mental health field and in the sociology field that say this stress, this particular minority stress, is why we see an increase in substance use, why we see an increase of depression, why we see an increase of anxiety, why we see an increase in suicide attempts, is this ongoing stress of living in a heteronormative world and not being cis or heterosexual. Okay, next slide. So this stress caused by such high levels of external stigma can disrupt an individual's psychological process, such as the ability to cope, regulate emotions, and achieve positive interpersonal relationships. So basically, this is saying this can impact all areas of their mental health. This can impact all areas of their social functioning. This can impact all areas of romantic and social relationships. So this stigma can become internalized, leading to identity concealment, self-hate, feelings of worthlessness, and fear of rejection. So again, as someone's processing this internalized feeling of self-loathing because of their sexuality or because of their gender, it's better to just not come out because I'm going to be persecuted. I'll just try to deal with it. I'll just sit on it. I'll just take these pain pills and then I won't feel so depressed. All this psychological pain, all this feelings of not being worthy, I'll just medicate it. I'll just shoot up some heroin and guess what? I'm not dealing with it anymore. So as we talked about earlier, people use opioids and people use other drugs as a way to escape their situation, as a way to avoid having to deal with stressors, as a way to get rid of the emotional pain that they carry all the time. So this sexual minority stress is one reason that a lot of people think we have higher levels of drug use and mental health issues. Next. So this is basically what I just said. So continuing to use drugs, as you know the pattern of how that works is that, first you're using to get high, then you're using to get by, and then you're using to not die. And so individuals, start out with maybe as a way to escape some of these feelings. And then before you know it, they're addicted to the substance. And then, which again, as we know, creates even more problems because there's then maybe illegal behavior to get the drug, certainly dishonesty, lying to family and friends about your use, financial problems of getting the drug that you need, and then making bad decisions while you're high. So this is why we have an increased rate of HIV and other sexually transmitted diseases, because as people use drugs, as you know, they don't make good decisions about sexual behavior, and maybe often take higher risk sexual behaviors rather than lower risk things. So next. Okay, so what can we do? So as with all patients suffering from opioid use disorder, MAT therapy, which I'm sure you probably work in or have heard about or deal with in lots of ways, in combination with counseling and behavioral health interventions, is probably the gold standard of treatment for people with opioid use disorder. So, there's always detox and abstinence, which is great. But there's also MAT therapy, which I'm a proponent of. I think, again, we look at it as sort of a harm reduction approach for individuals to be able to have an opportunity to see what life is like when they're not focused on heroin or they're not focused on getting pills. What can you do with that extra energy? What can you do with that time? Well, you can have healthy relationships, you can have a job, and you can see what it's like to live without being addicted to those substances. So there are considerations of using medication-assisted therapy if people are having hormone therapy, if they're on ART, which is medication for HIV, or if they're taking PrEP as well. But again, what we know works well in the general population obviously works well in the LGBTQ population as well. Particularly though, maybe things that are focused on a behavioral health level, and I'll talk about that in just a second. Okay, next. Okay, here it is, non-medical intervention. So looking at what can you do for individuals that identify in this particular group, obviously cognitive behavioral therapy is good for them, helping to challenge those negative thoughts about self, negative thoughts about situation, asking if there's evidence to support that, helping them to reframe those negative thoughts into things that are more positive, finding evidence to help them create new ways of thinking about themselves and their situation. That's basically what we do in cognitive behavioral therapy. Motivational interviewing. If you've not been trained in motivational interviewing, I strongly suggest that you go and take a course either online or in person. It's just such basic, great information about how to talk with individuals about their substance use, but also helping them set up some discrepancy between how they're living and how they want to live. Motivational interviewing helps us to let people identify what they want in their life and then help them see what the obstacles are for getting there. So motivational interviewing, big fan of that. I use it all the time with this population. I use it with, substance use folks. I use it in just general mental health counseling as well. And then gay affirmative therapy. So if you Google gay affirmative therapy, there's lots of different ideas about what is gay affirmative therapy. Basically, it's cultural competence. So it's all those things that I talked to you about earlier today. It's about understanding sexual minority stress. It's about understanding internalized homophobia. It's about understanding the coming out process. It's about accepting people for who they are with unconditional positive regard and bringing that into counseling sessions with them so that they think, oh, this is a safe person. This person understands not only my addiction, this person understands the unique challenges that I face on a day-to-day basis. So when you can do that, when you can have this affirmative approach to therapy and the patient feels like that you get them, that you understand what they're going through, that you understand their situation, then what we've noticed in outcome studies is that counseling and recovery numbers are so much better, because suddenly my counselor or my sponsor or my therapist, they understand me, they get me. So the work then comes much easier and much quicker. All right, I do want to say one thing that I've noticed in my practice here issues with AA and NA for opioid use disorders and LGBTQ people in particular. So let me start out by saying I'm a big supporter of AA and I'm a big supporter of NA. I think that those groups have saved so many lives, and I think it's, for most people or a lot of people, it's a great way to go to treat substance abuse issues. Just like everything in life, one size does not fit all. So it's going to work for some people and it's not going to work for other people. Particular concerns I have for folks that are on MAT and maybe Suboxone particularly, if they go to some meetings, to some 12-step meetings, NA meetings, a lot of those folks or I've had a lot of my clients and patients tell me they don't feel welcome in those meetings. And this is the reason why. They say that other people in those meetings will tell them that they're not in recovery, that they're still addicted to a medicine. And, you may believe this too, I don't know. But they sort of say to them, you need to get off that Suboxone, and that they feel unwelcome and looked down upon. Now, what we know is if someone's going to a self-help group, coming out of a self-help group and feeling like you've been ostracized and that you're not doing it correctly and that you're not welcome, sort of defeats the purpose, right? So what I've had other folks that are on Suboxone do is they'll go to a meeting and then they won't tell people that they're on an MAT. They won't tell people that they're taking Suboxone. So they're lying to the people in the meeting. Now, recovery is based, one of the cornerstones of recovery and sobriety is being honest, right? So if you're having to go to a meeting and sit there and lie the whole time, I don't know that feels really good either. So there are now, support group meetings, particularly for people that are on Suboxone, other MATs. So I encourage people to go to those. And if they can't find one, I encourage them to start one. And so we've done that here at the university, where we have support group meetings, particularly, just specifically for folks that are on MATs, and that's important. The same thing, I guess we can extend it to LGBTQ folks. You don't want to send people to a meeting where they're going to be bullied, or they're going to, perhaps it's maybe very spiritually, religiously focused, and then an LGBTQ person comes out of there feeling like they've been harassed, or that doesn't align with their beliefs. So caution in referring people to meetings where they're not going to feel welcome, or that somehow they're going to feel less than, because that's not what we want to do. Okay, next. So this is the other term I think that I wanted to just kind of throw out that you may hear at the end. We used to treat people with that identified as transgender, if they were having mental health, anxiety, or depression, we would call that gender identity disorder, right? The distress that they were feeling around their gender and their identity didn't match, and so this somehow was a mental health disorder. That changed when we realized, wait a minute, we're blaming an individual for what's going on because of society. So what we now have is the diagnosis of gender dysphoria. In other words, when an individual feels that their gender identity doesn't align with the gender that they were assigned at birth, and this feeling of not matching up, if they're experiencing some kind of mental health issue because of it, just depression or anxiety, or feeling bad about themselves, that's what we're identifying as what we're treating, are those negative feelings associated with the discrepancy in their gender and how they feel about themselves. So that's the new term that we are currently using. Next. Okay, so again, this is a recap. You can just pop through all those, John. These are the things that we've talked about. There's increased use of substances, mental health issues. There's an increased risk of suicide attempts. There's this idea of not accepting oneself, of internalized homophobia, and the role of sexual abuse and violence is also greater in these individuals as well. So they suffered more physical and sexual abuse and violence growing up and in their relationships as adults. And oftentimes they have limited social outlets, particularly maybe in rural areas with clients that you see that don't know how they can connect. Next. Just a quick word about methamphetamines. You know, we're seeing an epidemic in the gay male community in particular, with a rise in meth use. You know, this was, everybody has their, ideas about why this is the case. For me, I feel like when we regulated opioids in some ways that they weren't as available in pill form, people again started turning to heroin. They also started turning to other drugs, particularly in the gay male community. I think this was a party drug, one of the party drugs that was available. This is something you should ask about if you're treating someone who identifies as a gay man, to make sure that you're treating this if this is an issue. But we can talk about that some more next week if you want to. Next. So here's some do's and don'ts. Don't label your clients and feel like you understand exactly what's going on with them. You need to ask them and be sure. As I mentioned earlier, don't pressure your clients to come out. You can talk about coming out, talk about where they are in that process, maybe talk to them about what obstacles they're facing with it. But remember, they have to do that in time that feels right and feels safe for them. Don't ignore significant others and family members in your treatment. You know, that's their support system. So it would be important to find out if they have a partner. And don't be afraid to bring that partner into a session if you possibly can. Don't interpret on behalf of the client. So in other words, don't assume you know what it's like, the struggles they're going to. It must be really hard being a lesbian in, out here in where y'all, Bourbon County, I think, or some what other counties you are, Millersburg. It must be hard being a lesbian in Millersburg and no other lesbians around. Don't do those kinds of things. Don't say those things. You must be angry at your parents for the way they treated you, or I don't blame you for not going to church. Those kinds of statements, even though you're trying to align with an individual, you're making some assumptions that could be rupturing to your relationship with them. So instead, follow your client's lead about what they want to talk to. And it's always appropriate to say, tell me some more about that. Tell me what that's like. What's your experience with that? What's that been like? Is a better way to go. Next. So what you do want to do is continue to learn more about the LGBTQ population and the struggles that they face. You do want to ask about their coming out experience, because again, I think that's a way to really understand some of the maybe issues they struggle with, the traumas that they dealt with. You do want to acknowledge the significant others, and you want to be guided by your client, asking about things like pronouns. What pronouns do they use? What name do you want me to call you? That should be a standard whenever you do a new assessment with someone, is to say, hey, how do you want me to address you? Because it may be different. Okay, next. And finally, this is a great book. I meant to check on the SAMHSA website to see if it's still available. But if you can get your hands on a copy of this, I used to send it out free to anybody that wanted one. And I didn't check, so I can't tell you for sure if it's still available or not. But usually you can go to the SAMHSA website and they would send it to you. You may have to buy it now, or you may have to go on Amazon and see if you can find it. But it's got a lot of great information as well.